welcome. I'm Bob Cusack, Editor-in-Chief of The Hill. Thank you for joining us for Rare Diseases, a conversation on value assessments, where we'll be exploring how to increase availability and access to orphan drugs. We'll be using that term a lot today, so for those who don't know, this is the term for therapies used to treat rare diseases. Before we begin, I'd like to thank our sponsor, Alexion Pharmaceuticals, for its support of today's event. And I'd also like to take a moment to thank my colleague Julia Manchester for joining me today to facilitate these important discussions. Apart from the two of us, The Hill's editor-at-large, Steve Clemens, will also be making a cameo or two along the way. 1 in 10 Americans suffers from a rare disease. That's 30 million Americans who need access to treatment. Since the passage of the Orphan Drug Act in 1983, progress has been made in researching and developing drugs for the 7,000 rare diseases currently identified by scientists. Still, many diseases lack adequate therapies, preventing patients from accessing new innovations. What are some of the unique roadblocks drug manufacturers face when developing orphan drugs? How can we encourage new breakthrough treatments at prices patients can afford? And what can policymakers do to increase innovation and access to orphan drugs for all patients? We are going to be putting these questions and more in front of our fantastic speakers, but first, a few housekeeping notes. You can tweet us at the Hill Events using the hashtag #TheHillRareDiseases. We are broadcasting live and will be taking your questions throughout the program. As with any live stream, you could experience occasional trouble with the video. Refreshing the page should, in most cases, fix the problem. My first guest is Congresswoman Anna Eshoo from California. She's the chair of the Health Subcommittee and has recently introduced legislation to create the Advanced Research Projects Agency to develop disease treatments that would otherwise struggle in commercial markets. Welcome, Congresswoman. Really appreciate you joining us today.
I'm delighted to be with you. Thank you for inviting me.
Well, first of all, a little news of the day. Build Back Better. The House is waiting for the Senate to act. The big question of the week, month is, do you think Congress and Democrats, because there are no Republicans supporting this bill, can get this bill done through the House and the Senate by Christmas?
Oh, I think it can be done by Christmas. It should be done by Christmas. Nothing is going to change beyond Christmas. So I think that it would be a gift to the country if the Senate acts and it's passed and sent to the president for his signature. There are so many important policies in it that the country is going to benefit from. So pedal to the metal.
You are, as I mentioned, you're the chair of the Health Subcommittee. Can you just tell us, before we get into the rare disease issue, just what's on the agenda for your Health Subcommittee? It's a very important subcommittee.
It is a very important subcommittee. Of all the subcommittees of Energy and Commerce, we have the most bills awaiting our action. So many bills that are referred to the subcommittee. So we have been the most productive subcommittee of Energy and Commerce, but I always want more. I want to take up more, pass more, so that not only my constituents, but the American people benefit from what we do.
As far as rare diseases, I used to cover health care, and a lot of the focus is on Medicare and Medicaid and those type of things. What drew you to rare diseases? Because it doesn't get as much attention as it deserves.
Well, these are people that are awaiting not only the actions of the Congress, but live daily hoping and praying for breakthroughs because they have a rare disease. And so there are many challenges around this, both for the drug makers and then, of course, for patients. It's a challenge for drug makers because it's a smaller universe of patients that will be partaking in the drugs that they bring forward. So it's not only a smaller patient population for these rare diseases, it makes it difficult, as I said, for drug makers to identify and recruit participants in the trials. Now, in the 1983 Drug Act, as you stated, that there were incentives that were built into that law, that they would have marketing, 7 years of marketing exclusivity. There was a 50% tax credit that was attached to it. The tax code is motivating across so many sectors, but this one in particular. Now, in the 2017 Republican tax cut package, they reduced the tax credit to 25%. I think that it should move back up. Because the less motivation there is on the part of the drug makers to come forward and make the investments in these trials, and trials are really costly. I think that tax credit should move back up to 50%. And in the trials, because it's a smaller universe of participants, they often have financial challenges, mobility impairments, and so those are all areas that make it more difficult, that makes it different for the rare disease population versus others.
You mentioned that legislation in 1983. You have legislation on the Advanced Project Agency for Health. Can you tell us a little bit about this and where you see could this happen in the new year?
Well, it's a top priority of mine, Bob, and it's ARPA-H. We know from the defense side that DARPA was created many breakthroughs. Why? Because it takes on high-risk projects. And that has been extraordinarily successful. Many years ago, when I led the effort in the House for an innovation agenda, we created ARPA-E around energy issues. That too has been highly successful. So now ARPA-H. And this is different from other undertakings because it will pursue high-risk projects around not only rare diseases, but around those diseases where we have not made the kind of progress we need to make when someone receives a diagnosis that is a death sentence. Glioblastoma, pancreatic cancer, ALS. These are horrible diseases. And as I said, when someone receives this diagnosis, it is a death sentence. So this is a vision of the president. And I think that an ARPA model is the model that we need to pursue. So I'm very excited about it.
Is there a Senate companion? So if, getting it through the House, obviously you're a leader in the House. Do you think it could pass the Senate as well?
Well, I think so. I've spoken to Senator Murray, who is the chair of the Senate Help Committee, and I believe that we can get this over the finish line. A lot of people are waiting for this in our country, and I'm very pleased that academicians, scientists are supporting this legislation because of the approach. So, as I said, it's a top priority of mine, and I look forward to getting this over the finish line. Get it to the president for his signature.
I wanted to ask you about COVID-19, kind of a two-part question, because we used to do these events a couple of years ago. We'd be sitting side by side. Do you have optimism going forward on COVID-19 that we're going to get back to a semi-normal situation in the new year? It's been a very frustrating 2 years. And I guess the second part of that question is, are there any lessons from COVID-19 that we can apply to rare diseases?
Well, I think in terms of lessons learned, what COVID has laid bare are many of the shortcomings in our system, our supply chain. It seems kind of deeply buried in the past now, but I remember being on the phone with hospitals that were desperate to get supplies, some of the most the supplies just for the workforce. And so we have a lot of work to do to really repair our supply chain. We should not be dependent on foreign countries for this. I am more than hopeful, though. And the reason I say that is we have the tools in the United States. We have the breakthrough in terms of the drugs. We have the vaccinations. We have the platforms that have been established in communities across the country. And so, where other countries are literally begging for the vaccinations, we have them. I think our greatest challenge is to move the population of our country to be vaccinated, to receive the 2 shots, to get the booster, because we know that without them, if we have 25 to 30% of the American people that are not vaccinated, we are holding ourselves back. I think that's our biggest challenge. The policies we can certainly put into place, and we've been moving to put those in place, but people need to be vaccinated.
Last question, the disparity in dealing with rare diseases. Is there one in certain parts of the country, because healthcare generally, as you well know, it's advantageous to be in certain parts of the country because the healthcare is better. Is that the case with rare diseases?
I think the case with rare diseases is more with the drug manufacturers, what will motivate them, certainly through the tax code, to actually enter this space. Everyone needs to realize that when they produce a drug, and we've been very successful with the 1983 Act. Prior to that, the FDA only had approved some 38 drugs. There are over 770 that have been approved since this law was put into place. But I think that there needs to be some policy and tax changes around the tax credits, certainly. And I think the costs of the trials and the limited number of people that are placed in them. I think if we beef that up and make it attractive to drug manufacturers, that once the drug is approved, obviously it's a smaller population of people. It's not the entire population of the country, that more of these drugs will reach the population that so desperately needs them.
Are those the biggest roadblocks for both manufacturers and patients, the incentives that you mentioned, tax credits, or is there something else that's even bigger?
Well, I think that in my view, that is. Now, the drug manufacturers certainly need to come forward to Congress and identify other roadblocks that I may not be aware of. But I think that restoring that 50% tax credit is very important, because they have to make a large investment. Every drug manufacturer has to make a large investment in clinical trials. They're expensive. So certainly the exclusivity, the 7 years of exclusivity, but also restoring the 50%, I think would be most helpful. And I do think that we get ARPA-H over the finish line, that would be a boon to the rare disease sector in our country.
As far as, we talked a little bit about where you live, but as far as disparities and minorities, is that also something that needs to be addressed as far as rare diseases, that if you're not white, then you have a more difficult time actually getting the treatment you need?
Well, it's a very important point that you make, Bob, and that, I think, needs to be addressed in the clinical trials. You need to have minorities. I'm drawing up legislation on that right now, and there are other bills that are in the hopper relative to the clinical trials. Minorities need to be a part of that because they will be part of the rare disease community that will benefit from the drugs once they hit the market. And it's not a fair market, I would say, if minorities are not included in clinical trials.
It's such an interesting discussion, but I do want to ask about, you mentioned supply chain earlier. Would your legislation address that? You know, what's the fix there?
Well, there are many fixes that need to be addressed. Certainly in terms of the medical supplies. We saw healthcare workers in hospitals wrapping themselves in garbage bags. In the United States of America, we have that? I don't think so. So there is legislation that addresses that. I think that a lot of manufacturing really needs to be done in the United States. There is a race to the bottom in terms of costs, and then we paid a huge price for it with this pandemic.
Well, Congresswoman, thanks for joining us. It's such an important issue. We all know people who have rare diseases, and thanks for your work, and thanks for this discussion. I really enjoyed it today.
Well, thank you for inviting me. It's a pleasure to be with you.
Our first panel today is made up of physicians and rare disease advocates. Tammy Boyd is the Chief Policy Officer and Senior Counsel for the Black Women's Health Imperative, which recently launched the Rare Disease Diversity Coalition to address the challenges faced by rare disease patients of color. Annie Kennedy is the Chief Policy, Advocacy, and Patient Engagement at Every Life Foundation for Rare Diseases, a nonprofit dedicated to empowering the rare disease patient community. And finally, Dr. Deborah Regier is the Medical Director of the Rare Disease Institute at Children's National Hospital. She cares for patients with genetic and metabolic syndromes, manages day-to-day workings of the Institute, and conducts needed research on rare diseases. Welcome to you all.
Thank you.
So just to start off with, and Annie, I'll pose this question to you and you can kick us off. When I hear the term rare disease, as someone who doesn't work in a medical field, doesn't cover medicine or healthcare, my mind goes a million places. Just try to paint a picture for us as to what we're talking about when we say rare diseases, and who's actually impacted by rare diseases. What kinds of patients are more likely to contract them?
Sure. So we actually conducted a study that we published earlier this year that actually started to develop some real data around who's living with rare diseases in the U.S. And we found that of the data that we looked at in 2019, there were more than 30 million Americans living with rare diseases. One of the hard things about this data is that our rare disease community is actually pretty invisible here in the U.S. because the way that we track that data is through a coding system. And then of the estimated 7,000 to 10,000 rare diseases in the U.S., we actually only have codes for 500 of them. So we know that that 30 million number is a gross underestimate of the number of people living with rare diseases. So we probably all have people in our families and in our communities living with rare diseases. We just can't really count them right now based on our data systems. So that interview that preceded us with Representative Eshoo was a perfect tee-up for us to talk about the opportunities to do better by our rare disease community.
Right, and Dr. Regier, what are some of the difficulties that you faced treating patients with rare diseases?
Great question. I think that some of those were actually already brought up in the earlier interview as well. Sometimes it's getting the diagnosis. We don't even know you have a rare disease unless we've made that diagnosis. And since rare things are rare, it's not always the first place that people go when they meet a new patient. So making sure that our healthcare facilities, our physicians, our providers at all levels are prepared to identify and diagnose a rare disease is really important. And then access to care following that diagnosis. So it's the whole pipeline of providing care for families and patients with rare disease. And sometimes we think that it's all pediatrics. I happen to be at a pediatric hospital, but we know rare disease affects people of all ages, children's, adults. I always laugh that I take care of patients from prenatal all the way to the grave, whenever that grave is for them, because rare disease affects the entire lifespan.
Tammy, it's interesting. Earlier this week, Vice President Harris held a bit of a summit at the White House talking about Black women facing challenges when it comes to maternal health. And this isn't only an issue when it comes to maternal health. It seems like minorities and people of color really face different standards, unfortunately, when it comes to getting the health care they need, when it comes to treating a disease and getting, like I said, health care. What are some of the challenges that are faced by minorities with rare diseases?
Yes, it's a great question. I mean, generally we can say that rare disease patients have a unique set of care needs and access obstacles, from onset of symptoms through diagnosis and access to quality care. But then people of color face their own set of impediments to achieving good health outcomes, from protracted diagnosis delays to reduced access to specialists and treatments that meet the standard of care. And so really it's this layering of access burdens and health disparities that leads to a higher burden of disease and greater mortality in people of color with rare diseases. So yes, I mean, in terms of the maternal for Black women, which we advocate for a Black Women's Health Imperative, I mean, the disparities really run across the spectrum, but I mean, it's really no different in rare disease. And in fact, in addition to those unique set of needs and access obstacles, you also have some of the other layering of the access burden and health disparities that lead to a burden of disease.
And can I maybe add to that?
Of course.
We found in our survey that the average diagnostic odyssey in rare disease was over 6 years and included 17 specialists and providers. What's really important, though, while that's staggering if you think about that, that's only representing people who had a confirmed diagnosis, so who got to the end of that diagnostic odyssey, who was able to have a code that, again, we could track, and that's an individual then that was able to navigate a very complex healthcare system that had health insurance coverage that enabled them to get to 17 specialists and providers, and then oftentimes that requires travel out of state and paying for childcare when you were doing that. So I think that really underscores everything Tammy is talking about here, that again, we're creating additional health disparities within our rare disease community because of the complexity of navigating diagnoses and care and needing to really see experts and specialists within a very complex specialized community.
Annie, you make a really interesting point talking about the cost of childcare, the cost of healthcare, having to travel to get healthcare. Tammy, would you say this is an economic issue as well? And, also I'll tack on another question to that. I mean, it's 2021. You have people like the Vice President of the United States looking to really draw attention to these disparities that minorities face in healthcare. What are behind these disparities? Why are we still facing them now when, at least at the surface level, it seems like a lot of major figures, a lot of organizations are trying so hard to make this progress?
Yeah, absolutely. And this is one of the reasons why we launched the Rare Disease Diversity Coalition, which, again, as you mentioned, really brings together a multi-stakeholder groups. It's industry, it's patient advocacy groups, equity groups, rare disease patient advocacy groups as well, and really having everyone at the table to come up with solutions that address the challenges. And I think it really takes just really having everyone at the table collectively. For example, we at Black Women's Health Imperative have been working a lot on ICER and making sure that we include the quality of life and how ICER values life, for example, for Black women. We worked with them on the MG, myasthenia gravis, ICER review, and then also the lupus nephritis review as well. But I think it takes going to deeper and looking at some of those layered areas where we may not be factoring in, for example, in clinical trials. I mean, that is really a guidance for a lot of the data that we have. So we have to make sure we have minorities included in those clinical trials. So I think it's several different issues, but great part is that I think COVID has really, I mean, us in health disparities, we already knew that these disparities were there, but now there sort of seems to be like a renewed momentum to really address and really get to the root causes of why these disparities continue to exist.
And that's such a great point you bring up about COVID, Tammy. I mean, talking to other healthcare professionals at previous events we've done with the Hill virtually, it seems like the pandemic has had such a big impact on the industry, obviously. Dr. Aguirre, I want to go to you on this one. I mean, how has COVID impacted the treatment of rare diseases as well as the research into rare diseases?
Yeah, when you think about the treatment of rare disease, we have this saying in the rare disease population of our families know how to quarantine. Our families knew how to hunker down and stay safe like none others. They have community, they have an amazing bandwidth to figure out how to navigate complex situations, as we've heard, and they did a great job. It's been amazing to me how the rare disease community, the family communities have, they've stuck up for each other. They're in this thing together and they're finding new ways to live life. The other thing that we've seen is with the launch of so much more telehealth, I think that's really helped these communities, especially individuals that might be in rural communities or communities without direct access to a rare disease specialist, by having some of those state lines able to do more telemedicine. It's allowed us to get into homes that we haven't always been able to get into traditionally without telemedicine. So that's been a really big boon to how do we do treatment? How do we keep people at home safely and keep them on treatment even if they can't get into a healthcare facility? And I'll be blunt. Here at our center, we're still at 40 to 50% telehealth because it's the right thing to do for rare disease families. Having them stay home, having them not have to come into a hospital has been really effective at improving quality of life for families. Why are you in our hospital if you don't have to be? And then when we think about research, I think a lot of what we're thinking about now is how do we bring that research table to the population instead of expecting them to come to our table? How do we reach out to them using what we've learned through telehealth? How do we reach out to people in their homes? Research studies that you used to have to come to the center to get that blood draw, to get that exam. A lot of the rules have changed and we can do those on telehealth, which is amazing. Think about the people I can enroll in a study now. If I can do a telehealth research visit, instead of having you have to travel 8, 10, 12 hours, it allows people without access to some of those resources for travel to participate in studies. So I don't want to downplay the impact of COVID on our population, but I think taking what we've learned and saying, how can we do better in the future is going to really move rare disease research forward.
Annie, I can't imagine what it's like to have a rare disease or, have a rare disease, let alone during a major global pandemic, and have that extra stress put on me or, whoever has the rare disease. Talk to me about what's it like, what a day in the life is like for a patient with a rare disease, before the pandemic and also during the pandemic.
Yeah, and I totally agree with what everyone here has said. I think it's really important to remember a lot of those wonderful innovations that were just discussed were things that were actually enabled through 21st century cures, and the urgency of the pandemic really helped us to implement them. And there were things that the rare disease community have long been saying we needed and we could have, but the pandemic really lit the fire under us to do it. I do think it's important, though, to remember, and as Tammy was just saying, 60% of the costs of living with a rare disease are actually incurred out of pocket by individuals living with the rare disease. They are not the direct costs that we see in the healthcare system. They're the out-of-pocket costs. They're the non-medical indirect costs. During COVID, those costs were exacerbated because caregivers couldn't come into your home. So the caregiver reimbursement wasn't happening outside of your home. It was now in your home. You were still working, your children weren't in school, and your personal care assistant couldn't come anymore. So that exacerbated that. The other thing is the urgency in rare disease is that the life expectancy for people living with rare diseases is often significantly curtailed. It's estimated about 50% of people with rare diseases won't live to see their 5th birthday. So one of the things that happened during the pandemic was that clinical trials were halted. There were a number of reasons for that. We couldn't screen for the trials. We couldn't enroll for the trials. People couldn't get to trial sites. The exact people at the FDA that were doing the amazing work of reviewing our vaccines and the therapies for COVID were the same people that review our rare disease products. So we had a workforce issue. But when we halt and slow trials in rare disease, we lose a generation of patients in rare disease if we halt trials for 2 years. The other workforce issue we had was that the public health programs that were also being pinched by COVID are our same public health programs that do newborn screening for us. So that hurt our diagnostic programs. And so we, again, have workforce capacity issues that immediately impacted our rare disease community. So we have a lot of solutions before Congress right now to improve workforce capacity. We have to increase funding in rare disease, into research, into diagnostics. We have to make sure those public health programs are reinforced. And if we don't do that, the public health urgency of rare disease will only be exacerbated. These wonderful, the implementation that came out of COVID will not be lasting. And we also have to make up for some of these losses that we had over the last couple of years. The other thing is that we just heard Representative Eshoo talk about the orphan drug tax credit and how incredibly important that has been in innovation. But the orphan drug tax credit is threatened right now. And that innovation isn't just important to companies, but at the end of the day, it's important to companies because it saves the lives of rare disease patients. And just to talk about that for a second, the proposal that's right now in the Build Back Better Act would discourage companies from not the first therapy, but for the second therapy. And what that means is that there are countless examples of rare conditions that benefited when the first investment was approved and they moved on to the second rare disease therapy that may never have been developed if there wasn't an incentive to develop it. And we cannot afford for the rarer of the rare therapies to not have therapeutic development and companies not to have the incentives that are working. So there are so many wonderful proposals that will move us forward, but there are some that could really hurt us if we move those forward. We need to work together to make sure that the promise of innovation is fulfilled for those this generation of patients living with rare diseases.
And on that note about the orphan drug program, I want to pose a question to all of you, and I'll start with you, Tammy. How does one balance the issue of cost as well as innovation when it comes to the development of these orphan drugs?
Yeah, absolutely. And I just wanted to also comment on a point that I think Annie said when you talk about the out-of-pocket costs. I mean, it's even harder on African Americans. So that's even an example. Or telehealth, even as we saw in COVID with telehealth, there's the digital divide. Do minority communities even have access to that? So even as you put those things in place, looking at the systems that also providing access to such things such as telehealth to even be able to do that. And then such as the question around what do we do in terms of the orphan drug tax credit? I mean, we, for example, at RDC, we sent a letter, definitely advocating and pulling those stakeholders together to really just raise the issue around the orphan drug tax credit. But then also, again, there's looking at ICER and how do we engage with them and look at some of their guiding principles. I mean, they see their role as more promoting fairness and taking a payer perspective on things. And so, we have been in there really talking about including minorities, particularly rare diseases, in any of their economical or any of their statistical analysis.
Dr. Regier, we've talked about minorities and how they're impacted by rare diseases and the disparities in the treatment they receive, but I wanted to talk to you about the issue of children with rare diseases and really how widespread this issue is among pediatric patients.
Yeah, and I love that we've already mentioned that if we look at all rare diseases, 50% of children or 50% of individuals with rare disease have a life expectancy of less than 5. That gets into this idea that this has traditionally been thought of as a pediatric issue. So pediatricians are really well versed in rare disease, but we have to remember that the other 50% of the population often makes it into adulthood. So we're trying to expand that education out of just pediatrics. But when we think about my favorite patient population with is peds, that's why I'm here at the Children's Hospital. When we think about how do we ensure that they have access to care, it's one of the reasons that the National Organization for Rare Disorders went ahead and did a Centers of Excellence program to ensure that individuals could identify a place that understood rare disease, hopefully close to their community. This year, they announced 31 locations across the country that are centers of excellence. And by doing that, we're trying to create a network so that we can build best practices. As you can imagine, working with the Black Women's Health Imperative, which has been an amazing organization and have made so much progress, thinking about how do we best ensure that every child with a rare disease is first identified and second has access to care and treatment, regardless of what part of the country they're from, regardless of their background, whether ethnic or socioeconomic. No matter what, we need to make sure we find those children, we find them well, and we give them the best quality of life we can possibly do it. And at the same time, continue to encourage the research we need so that these aren't life-limiting disorders. Instead, they're life-changing disorders. That's always our goal in rare disease. Let's have life-changing, not life-limiting, so we can improve quality of life and outcomes.
So turning our attention back towards Capitol Hill, we heard Congresswoman Issue talk about this, rare diseases and, the work she's putting into this issue. But how many people outside of the Congresswoman on Capitol Hill are actually aware of this issue? I mean, to be honest, it's not something you hear every day in the news media or even in healthcare coverage. And maybe some of that's because of the fact that we're in the middle of a global pandemic and that sort of overshadowed the coverage. But Annie, I'll pose this to you. I mean, is there enough awareness among major stakeholders in Washington on this issue?
So wonderful. I would say there's never enough awareness, but I would say we're really grateful to have our Rare Disease Legislative Advocates Program works closely with the Congressional Rare Disease Caucus. So we have a wonderful group of leaders within Congress who are champions for our rare disease community and work very hard on behalf of our rare disease community. We have a lot of issues that are of great importance to our rare disease community right now, but a lot of really amazing, wonderful opportunities. I think in the context of today, the topic of value assessments in the rare disease community, I think it's really important that as we look at the really critical vehicles before us, HERES 2.0, ARPA-H, PDUFA 7, there are some really important priorities for our rare disease community that have to be front and center and central. And we're grateful to the Congressional Rare Disease Caucus for ensuring that that's the case. But as we look at this momentum and movement of patient-focused drug development that's really taken hold over the last 10 years, and value assessments, we have to ensure that patient-focused drug development is not just informing clinical trials and care and regulatory decisions, but it's also informing our decisions within the access ecosystem. And again, we're looking at the cost of overall care, not just the cost of prescription drugs, because we only have treatments for less than 500 of those 7,000 to 10,000 rare diseases. And we have a lot of data to show that it is not prescription drug costs that are driving the costs in rare disease. And we have to ensure that as we assess what's happening in rare disease, we are looking at how we reduce the overall cost of living with the rare disease overall. And we continue to inform the incentives to improve those health outcomes, as Dr. Rieger was just saying, for our rare disease community. That is our number one priority, and we're grateful to Congress for really being champions of that with our greater community.
Right, so we only have just a few minutes left, and I'm going to ask everyone to take out their crystal balls and we'll do a little lightning round. What's the future of research in this field, and what can we expect in the field of rare diseases going forward as we hopefully, knock on wood, get on the other side of this pandemic? Tammy, I'll start with you.
Yeah, I think there seems to be a renewed focus on addressing equity and disparities, that we're going to look at it from a more holistic approach and bringing in the social determinants of healthcare, which again, what you asked earlier, like what are the different layers and why? And so addressing, access to transportation, access to telehealth, access to healthy food, safe environments. So I think looking at it from a holistic standpoint it's probably what our future is looking like.
Right, and Dr. Regier, we'll go to you next.
Yeah, my crystal ball is we should have a lot of hope and joy in the future. Looking at the past where we've been, we're not there yet, but we have seen improvements in quality of life, and that's where we need to be. That's what we're going to keep doing. We're not going to let this momentum leave us behind. We're going to keep moving forward, improving every day, every life that we can in rare disease.
And Annie, wrap us up.
So the science is here for us. So as long as we invest at the level that reflects the public health crisis of rare disease, our patient communities will have more options, more hope, and more investment in rare disease research that they deserve and warrant.
Ladies, thank you so much for joining us. This has been such an insightful conversation. I know I've learned a lot. I hope our audience has as well. Thank you so much for your time. Tammy Boyd, Chief Policy Officer and Senior Counsel for the Black Women's Health Imperative. Annie Kennedy, Chief Policy Advocacy and Patient Engagement Officer at Every Life Foundation for Rare Diseases. And Dr. Deborah Rieger, the Medical Director of the Rare Disease Institute at Children's National Hospital. Thank you all so much for joining me.
Thank you.
Thank you.
Great discussion. Now I'd like to introduce a message from our sponsor, Alexion Pharmaceuticals. Please welcome Barrett Thornhill, partner at Forbes Tate.
Hi, everyone. My name is Barrett Thornhill. I'm a life sciences partner at Forbes Tate based in Washington, D.C. Today, we have Jason Schafran, Senior Managing Director and Economist at FTI Consulting based in Los Angeles. As you all know, the cost of drugs is a perennial hot button issue on Capitol Hill, and this Congress, as well as the White House, are currently stepping for more aggressive approaches to controlling prices. Jason is here to talk with us today about the merits and concerns around health technology assessments, particularly for rare diseases. He has extensive experiences, specializes in developing value assessment methods for innovative treatments. Jason, welcome today. Thanks for joining us.
Thanks a lot.
Jason, before we get into the issues related to costs and HTAs, tell me more about rare diseases.
Great. Well, in the U.S., the Food and Drug Administration defines rare diseases, excuse me, as diseases that affect fewer than 200,000 Americans. For rare diseases, about 37% of them, people have premature mortality. They die early, and most all of them, they have poor quality of life. Now, the Orphan Drug Act was passed in the 1980s, and that helped stimulate new treatments for these rare diseases, but over 90% of patients with rare disease don't have any available treatments. Some examples of rare diseases could be amyloidosis, which is a disease that causes nerve pain, affects your ambulation. It also may cause heart failure and arrhythmias. There's spinal muscular atrophy, which affects kids. In fact, for 2/3 of patients with spinal muscular atrophy type 1, they will die by age of 2.
Wow. So now that we know a bit more about rare diseases, tell me more about health technology assessments or HTAs.
Yeah, so health technology assessment, actually, that started in the US, surprisingly. So the Office of Technology Assessment was started in the 1970s as a government body. It didn't have any binding authority, and it actually was disbanded in the 1990s. But health technology assessment as a kind of binding government entity, that spread across Europe, Asia, Latin America, and in fact, there's now over 40 different HTA bodies around the world. And what does HTA do? They do 3 principal things. So first is they synthesize the value, the kind of clinical value of a new treatment. So, if they have a bunch of clinical trials and data, they bring that together and they want to measure what's the effect on patient mortality, does it increase survival, and on their quality of life. And they put that all together with a metric called quality adjusted life years, which economists like myself use to kind of mathematically measure the health benefits. Now, the second thing they do is they say, is these health benefits worth the price of the drug? So you want to try to quantify the health benefits and place a dollar value on that. And then is the price too high or too low for the expected benefits? And finally, the third thing is they may have some decision-making authority. In some cases, their evaluation on whether the price is right or not, well, that may just be in an advisory capacity. In other cases, maybe that will have a binding decision about whether a government or health insurer will cover the drug, whether there'll be more cost sharing for patients. So those are kind of the three primary things that HTAs do around the world.
So looking at rare diseases, what is the problem with applying HTAs? And moreover, why is it difficult to apply an HTA framework for drugs for rare diseases?
Yeah, that's a great question. So for rare diseases, I think there's a number of technical and also some kind of philosophical issues. So on the technical side, you have, because they're rare diseases, you actually have few patients, and so you're going to have small clinical trials. So you don't have, tens and thousands of people in the clinical trials. It's smaller. The evidence is typically not as good just because there's smaller patient populations. You also may have single-arm trials. You may also want to measure, well, how does the drug affect, patients' quality of life? How does it affect how they feel? And ideally, you would do that in a way that's tailored for that specific disease. Obviously, there's not that many patients with each rare disease, so you're not going to get well-validated patient-reported outcomes. So that's hard to measure. You're either going to use a pretty generic measure to do that, or you're not going to. Also, often HTAs really just focus on value in terms of health benefits, but they'll ignore impact on health disparities in terms of whether a treatment can help get you back to work. Will it kind of reduce your functional status and your disabilities, make those kind of easier to deal with so your caregivers and your loved ones won't have to spend as much time taking care of you and that burden. And finally, even if you're able to solve all those things, the market for patients with rare diseases is small by definition. So you don't have that many patients. And in order to be able to fund the clinical research that you need to see if a drug is effective, you're going to have a high price, per person just to be able to fund that. So you have these technical issues, you have these kind of philosophical issues because of just the nature that rare diseases are very small patient populations.
So Jason, U.S. policymakers often look to how their peers across the pond are handling these situations. How have other countries been able to surmount challenges?
Yeah, that's a great question. So most countries that have HTA actually have a separate process or have some exceptions for orphan drugs that treat rare diseases. One example is an assumed benefit threshold, which if a drug is shown effective in a clinical trial, then they'll look at kind of what's the total cost to the country or the insurer. So you look at kind of the cost per person times the number of people. If that's below some threshold, it gets covered automatically. And that sounds like a really easy way to do it, but basically that is set pretty low. That's basically just a budget impact analysis and not an HTA. So that's kind of sidesteps the actual HTA process. Another one would be to have a specialized pathway. An example is in the UK, they have a highly specialized technology assessment approach where they have different standards for orphan drugs to kind of adapt to those. And while that, again, sounds good in theory, in practice, about 11% of treatments for rare disease are not approved in the UK, and it takes more than a year on average to get them approved. So this is still a slow process, and not all treatments are kind of passed through there. And a third one would be pre-authorization programs, where if there is a treatment available for kind of a broader disease and there's some evidence that it would work in a rare disease, countries may pre-authorize the use of it, but those are implemented very strictly and not, it's pretty difficult to get through that pathway.
So I'm sure you have some real world case studies you could point to. Would you walk us through a few?
Sure. One example would be, or can be, for the treatment of cystic fibrosis. That was a treatment that was approved in the US in 2015, but due to ongoing negotiations and the HTA process, it wasn't actually approved for patients in the United Kingdom until 2019. Another example is Spinraza, which is a treatment for spinal muscular atrophy. I mentioned that before. Approved in the US in 2016, and patients got access pretty soon after. In the UK, that was actually rejected in 2018. In 2019, there was a managed access program, which means that it was approved on a conditional basis, but only for a subset of patients. Manufacturers were required to collect extra data. And finally, only in May of this year was that actually approved. So again, in theory, HTA can have some exceptions. that this would work well, but in practice there are a lot of delays and a lot of back and forth, and patients are not getting access till too much later.
So tell me more about the utility of the HTA framework for rare diseases in the US, and also maybe highlight for us how the actual quality number affects these decisions.
Yeah, so in a typical health technology assessment, you're looking at the QALYs gains, which is again a mathematical construct that just measures survival benefits and quality of life. And one of the key issues here is that most HTAs treat those health gains as the same for everyone. So if you had some disease for a rare disease with people that are in a wheelchair that are really suffering, and you have a quality gain of 2, and you have someone else that is a regular disease, pretty mild, and you had a quality gain of 2, HTAs would say, okay, well, those are exactly the same. We value them the same. But if you go to the research, you actually see that people value treatments for more severe diseases more. So if you can treat really severe diseases with people who are highly disabled, have really poor quality of life, and bring them back to normal or at least a significant improvement, those QALYs, those health improvements should be valued more versus kind of the improvements for patients with less severe disease. And actually there's been some developments in the economic world looking at generalized risk-adjusted cost effectiveness to kind of account for that severity. But today, none of the HTAs really account for that in a rigorous fashion.
So Jason, I know economists can supply plenty of words on demand, but let's do a speed round to wrap up today's session. First, what is your best guess for when the US government would execute HTAs for new products?
Well, I think I'm going to be not as fast, but I think it's going to probably be take a while. I think there are some approaches where the government could have a kind of clearinghouse with health technology assessments done in the private sector. ICER, the Institute for Clinical and Economic Review, is one entity. The Innovation and Value Initiative is another. So there's kind of different approaches that besides just having centralized HTA, you could also have HTAs kind of validating quality of these evaluations, and then payers could decide which approaches they use. So I think that's probably coming, but I think for rare diseases, because of all the problems we mentioned, that's probably a longer ways away just because of those technical and philosophical challenges.
Well, if you were in charge of this, what would be the first product or the first class of products you would target?
Well, I think if you think about what ICER is doing, they have an unsupported price increase method where they're kind of targeting price increases. And although that's not kind of the core HTA, most HTAs will focus on high cost drugs, which is high cost per person and affect a high number of people. Those are the things they're going to target. And rare disease treatments, although those are maybe high cost per person, those certainly should not be prioritized. Those are the overall budget, because it's rare, it's not going to be so big. And these are people with really severe diseases. So, you would tend to focus on bigger diseases, more prevalent, more expensive treatments to make sure that those are priced correctly.
Great. Third, from a manufacturer's perspective, is a good offense on assessing a product's value the best defense?
Well, I think, generating evidence to measure value broadly is key. So kind of at the time of launch. So you'll have a new drug, you'll have a clinical trial that shows it works well, and then you're going to get assessed. And one of the problems is maybe you don't yet have evidence on, well, will this help someone get back to work? Will it improve their quality of life and functional ability? Will this help reduce the caregiver burden? Will this kind of reduce health disparities? And that evidence, the sooner you can have that evidence available, HTA bodies or even payers, Medicare, other people will have to take that into account. So I think the sooner you can generate evidence on how new treatments affect broader societal impacts, that's certainly very valuable.
Interesting. Well, fourth, as you probably know, the Build Back Better reconciliation package that's passed the House and is currently pending in the US Senate imposes straight price controls based upon the age of a product. Are HTAs better or worse?
So I would say, HTAs is just evaluating, what a treatment's price, could be. That could be done in an informative approach or not. But in both cases, if you have centralized government setting prices, that's fairly similar. HTA is, I would say, is superior than just kind of the age of the product, because at least you're incorporating value in a more comprehensive way. But still, both are kind of setting prices in a top-down manner and not taking into account variability in kind of what matters. Is it safety or efficacy, how those trade-offs are? What if we incorporate the caregiver burden? What about productivity? So I would say certainly HTA is better than just a very crude price setting based on the timeline. But again, centralized kind of price setting is not ideal in any such setting.
Gotcha. Well, last, here's the easy one: country or Western?
I'll say probably neither on both of those. I'll go with classical for me.
Fair enough. Any last remarks you want to get in?
Well, I think, one of the key things is, the Orphan Drug Act passed in the 1980s. I think that was certainly helpful for stimulating new treatments, but still over 90% of diseases, of rare diseases, don't have any treatments. And there are a lot of challenges on the cost front, but it is important to continue the conversation in terms of how do we continue to get access, how do we ensure that treatments are, priced to value, and I think that's kind of where we want to head forward together as a country.
Wonderful. Well, thanks for spending time with us today. Again, everyone, this is Jason Schafferin at FTI Consulting, and I'm Barrett Thornhill. Thanks again, and we'll see you soon.
Thank you so much for that fascinating conversation. Earlier, my colleague Steve Clemens, editor-at-large of The Hill, had the opportunity to speak with experts on pharmaceutical pricing and research as it relates to rare diseases. Let's take a listen to their conversation.
For our next panel, we're taking a look at some of the factors that go into assessing the value of rare disease treatments, from barriers faced by drug manufacturers when bringing these complex therapies to market, to making treatments accessible to patients who need them most. What data is most essential to bettering our understanding of these life-saving medications? To discuss this and more, I'm now pleased to be joined by two experts on pharmaceutical cost and research and how they relate to rare diseases. Dr. Ji Bai is a professor of healthcare policy and management and a professor of accounting at Johns Hopkins University, and Dr. Brett McQueen is director of the Center for Pharmaceutical Value at the University of Colorado. Folks, this is a topic that is pretty far from me. I'm sort of, remember the Schoolhouse Rock, thing on how a bill becomes a law, and it comes and says, hey, I'm a law. And I just kind of want to have like a Schoolhouse Rock of how a drug gets a price. Hey, I have a price. And so Dr. McQueen, let me just ask you, as you think about pharmaceutical value, and today we're obviously specializing on this question that, there are ailments out there where fewer than 200,000 people have it, and so classified as a rare disease. And to get the incentives right so that therapies and drugs can be developed to do that, we have this problem, but there's not the kind of market there, the same market forces and scalable market forces. I'm just interested in what you do. I don't know if you dream about pricing drugs, but be interested to know what's your North Star, or what are the set of parameters that should help our audience understand what goes into pricing drugs in this rare disease area.
Yeah, thank you for the question, and I appreciate you having me on. I think one of the most important things to understand is value assessment, largely the way it's practiced, is a synthesis of existing evidence sources. And that's often a function of regulatory approval through the FDA process, which does provide us with very helpful endpoints. But the problem of actually pricing in rare disease shows a lot of the data gaps that we end up observing through that FDA approval process. And that includes, obviously, small patient populations to test the effectiveness of the therapy. And so that leads us to want to capture more value around the impact that treatment can have on their lives. And it can be quite significant and largely different than what we would consider in other chronic disease areas. So it's a really important thing to understand that the underlying evidence is crucial, and there are a lot of gaps, obviously, with rare disease. And so that's kind of what I try to work on and contribute to and fill those gaps the best I can.
And Dr. Bai, let me ask you the same thing. I love that you're both a professor of health policy and accounting. That's a unlikely pairing. So you get numbers. But as you kind of look at this question of how we get the equilibrium right between the different players, and as Brett McQueen was just talking about, also looking at value, which is really looking at impact, because not all drugs work the same with all people. So there are these lot of squishy dimensions that I want you to make less squishy.
Yeah, thank you. I'm a bean counter. I would love to look at this issue from the monetary perspective. Right, drug makers, they have to make money. The reason they focus on one area is because this one area gives them potential return. The return on investment must make sense before the drug makers invest, right? So the rare disease is a category that has received a significant subsidy from taxpayers, from the Orphan Drug Act, right? So these kind of incentives really make a huge difference, motivate the drug makers to get into that area, get the most value out of it. At the same time, yes, it does create a lot of value for the patients. I want to mention, not just for that disease itself, it also prevents patients from getting to hospital, right? And that saves a lot of taxpayers' money and the patients' money. So it is from a pharmaceutical perspective, it's really an investment issue. Right. So now we have a lot of movement, right, on the Hill. I'm right now in DC. It's not far from where those fights are going on. So whenever we change any regulatory constraints or any legislative things, then there will be some impact on the return on investment equation. And then that will have some rippling effect on the downstream. For example, the investors, what they will think, and then eventually patients. However, I want to mention, the Orphan Drug Act was designed to promote innovation. However, evidence, and a lot of evidence has already shown some manipulation abuse. So there has to be some kind of balance, right, from the manufacturer's perspective to limit the political exposure, political cost, and reputation costs, so that eventually investors will be happy, patients will be happy, and that will be a best equilibrium, in my opinion.
Well, let me ask you one other thing, and I'm going to jump back to Brett in just a moment. But Dr. Bai, I understand that you have a worry that if we don't get these incentives right, that you could see a talent drain. You could have a capital drain from this, that the talent will get applied elsewhere because the incentives won't be right. Are you worried in our current climate of that happening? Do we need to do something to juice up the 1983 Orphan Drug Act and to provide, I guess, rejigger the incentives so that attention does stay in this area?
That's a great question. Thank you. I think in general, we must make sure as a nation, we put sufficient incentive into innovation so that we can attract a lot of money, not just from the United States, but from overseas to instill into our innovation, our drug companies, so that we can have the best drug that can be used by Americans as well as eventually everyone in the world. That would be the goal. However, in some specific scenario, let's say the orphan drug situation, rare disease, and we have the incentive. However, there are some kind of actions from manufacturers that creates, the political cost and reputation cost. I do believe whoever on the Hill, those policymakers, they have to follow what voters believe. If we have more and more evidence showing that some inappropriate behavior, abusing or manipulating, then that incentive might be gone. The politicians, no matter how much lobbying money they got, they will have to follow what the public believes. However, in general, as I mentioned earlier, we must make sure there's no capital drain. The capital must be attracted to this area, and no brain drain. If we don't have enough money to support, to give a good incentive for researchers, smart people will have to leave this area to do other things. That will be a huge loss for all of us.
Let me get back to Dr. McQueen, and Doctor, I am a fan, if you will, of the wellness push, the value-based precision medicine, because I'm very familiar that one size does not fit all in this sector, but the key is data. And I know my team didn't discuss this out of left field, I'm sure, but I'm really interested in how the data game is going, how health records are going, how transportable and fungible that information is, because my sense is it is very balkanized, that there are a lot of walls, that HIPAA and other things get in the way of the data that someone like you needs. So tell me where I'm wrong with that, because my sense is people just assume that data just flows. But the more I get into it, the more I realize if you're within a hospital system, you can get data there, but sharing between systems, tends to be weak in some cases. And then there are all sorts of other barriers to us accessing the kind of mass data that would be helpful in the kind of work you do.
You're absolutely right. I'm not going to disagree with you at all, Steve. I think one of the challenges, and this came up with PCORI, where PCORNet was developed. And while the advertisement is that the data generated is available widely to the public, that really hasn't become the truth, unfortunately. And further, just beyond that, we see multiple silos, like you said, in these different academic medical centers or community centers where you can only really access the data if you're a partner or if you're a faculty member or a researcher at that group. So I do think there has to be some barrier breaking, so to speak, in terms of making sure that data is available to researchers. And I'm talking large registries that we can access over long periods of time. And the cost should be minimal, because right now, one of the biggest barriers, if it is even available, is the significant cost that companies and researchers have to make to pay for to actually access the data itself. So you're right. You're absolutely right.
And just real quickly, just finally, Dr. Bai, do you find, because you're at Johns Hopkins, right? You're just down the road. You're very close to us. But I think, again, looking at health policy, do you think there are public policy responses on, data sharing that need to be put in place? When you look at where the U.S. Health system is, I'm always worried, how can our system become healthier than it is? We're talking about a quadrant of that today with rare diseases. But I am interested in why it's so hard to get the data inputs we need. And I'm just wondering what your perspective is.
Oh, well, I think the players, not only in this case, but in general, would always want to hide the data if hiding data would bring them more benefit, right? So eventually it has to be put enough incentive for the players to voluntarily disclose the data. So there has to be right incentive to make sure not only the eventual users, but the person who actually have to do the disclosure would benefit from it. Eventually it needs to be the incentive and make sure that action has a good return on investment.
Well, I really appreciate this. This is a quick snapshot, far too fast, but I hope you'll both come back and help me get educated, as we kind of talk about how to make this whole health ecosystem smarter and better. Thanks again to Dr. G. Bai, Professor of Healthcare Policy and Management and Professor of Accounting at Johns Hopkins University, and to Dr. Brett McQueen, Director of the Center for Pharmaceutical Value at the University of Colorado. Thanks to you both.
Thank you for having us.
And thank you to Steve and the panelists. And we're actually going to head back to Steve once more. He had the chance to speak with Indiana Congressman Larry Bucshon, who sits on the Energy and Commerce Health Subcommittee. Steve and Congressman Bucshon spoke about how to increase innovation and the rare disease space and making breakthrough treatments accessible to patients. Let's take a listen.
Congressman Bucshon, thank you so much for joining us again. I always enjoy our conversations. You get the health world, and I'm sort of a lay person on the outside. So if any of my questions are, not too informed, but today we're talking about something that's very important for many Americans, but
Yes.
but any rare disease, and we have a lot of people who suffer from rare diseases, but rare disease means it's someone who's suffering from something with less than 200,000 people in the United States. And we're talking about the health infrastructure around that. We're talking about pharmaceutical approaches to that, and I'd just be interested in your perspective on whether the way in which we're approaching health and the costs, the accessibility, and the innovation in this space is designed correctly from your perspective.
Yeah, well, let me just say this. First of all, thanks for having me on. And as you pointed out, roughly 1 in 10 people in America have rare disease. And, the Orphan Drug Act was created in 1983 to help develop drugs for people that have these rare diseases, because the business model for that is difficult for the pharmaceutical industry. And since then, about 7,000 different treatment options have been developed. But of course, it's an ongoing problem. And, my concern is in the current environment where pharmaceuticals are expensive, how do we proceed? How do we make sure that patients have access to all these drugs? And I do think that the federal government is going to have to continue to be engaged in that. The one thing I don't think the federal government should do is more broadly price fix pharmaceuticals across the board, even though I think we can all agree for the non-generic drugs, we need to get the cost down, and there are ways to do that.
So, that's a really interesting question, because you kind of look at this triangle of tensions, right? You've got innovation, and I've told a lot of my friends in the pharmaceutical industry that they ought to market their failures as well as their successes, because a lot of people don't understand the risk dimension that's involved in pharmaceutical development. That there's some flops out there that don't work, and so that's resources. On the other side, you have cost is a real factor in some of these, and so that's an issue, and that affects accessibility and coverage. But yes. I guess one of the things that's changed in my assessment is the out-of-pocket, the insurance industry. We always kind of look at prices from one corner, but price is covered by a lot of other players in the ecosystem. And I'm just wondering if you think that needs to be part of our discussion as well.
Well, it absolutely does. What has happened since the Affordable Care Act came into play, because of the insurance structure where everybody was put into the same pool, and we essentially eliminated health underwriting, because we had a group of people that were basically uninsurable, that we had to find a way to cover them. And there were ways to do that. I mean, as you probably know, I didn't think the Affordable Care Act was the best way. And what that has resulted in is insurance companies have increased their deductibles, and they've also decreased the number of things or the amount of money that they cover. And that includes pharmaceuticals, some pharmaceutical drugs. So what you've seen is, even though people knew that drugs were expensive, they didn't really have to pay for it out of pocket. Now more and more people do. There are ways that we can address that. We need to eliminate anti-competitive practices that are in the industry, and we need to simplify the supply chain that takes some of the middle people out of the mix. We have a whole plethora of middle people, pharmacy benefit managers, the plans themselves, the distributors, and others that will do perfectly fine if we create what I would call a competitive marketplace, so that there was more competition, that they would have to get their fees down. Particularly the pharmacy benefit managers are paid by what we call rebates, and that tends to result, in my view, in upward pressure on the list price for non-generic drugs. So there's a lot of things we can do. What won't work is having the federal government price fix, because that will result in a lot of pharmaceuticals just dropped off the marketplace. And that's not my opinion. The Congressional Budget Office said if we do these type of things, 10 or 15 new drugs won't be developed because over the next 10 years. And also some current drugs on the market might be dropped off because they just don't fit a good business model. So we got to be really careful here, but we do need to get prices down.
One of the things that really interests me about this particular topic, because I think that the answers are, nuanced in some ways, that when you sort of look at the price of a drug, an orphan drug, I think there's a legitimate question at hand of how you price it, right? Because you're dealing with an innovation directed at a relatively small group of people, right? So our healthcare system and a partnership between, government and NIH and private firms that are engaged in research and development are trying to develop a therapy and a response in that area. But you're never going to get the market scale of some of this. And so I'm interested in whether you know of any models that cannot undermine innovation and investment, at the same time be reasonable and affordable by the system, by however is paid, so that those two can coexist, both tracks, as opposed to kind of creating a price structure that destroys the innovation sector, or an innovation expense that just seems to be priced too exorbitantly. So I'm just sort of interested in whether you see there are models we ought to be considering.
I mean, you've outlined the exact debate that I think the American people and Congress are having. How do we accomplish all of these things? How do we make sure that orphan drugs and drugs for rare diseases can get to the marketplace? And how do we not have them be so expensive that the people that need them can't afford them? And on the other hand, how do we make sure that whatever we do, we don't stymie further innovation by price fixing the drugs at a low cost so there's no business model for them to be developed? That's the debate. I mean, honestly, I don't have a specific answer for you because I think we have a ways to go. I think there are things we can do. And some of that in some of these drugs is just going to be that the federal government is going to have to be engaged in this as far as payment goes. And that's like the orphan drug situation, right? I mean, there's not a good business model for some of these. And in that way, I don't have an issue really with the federal government helping to support patients by covering some of these drugs in some way so the out-of-pocket cost is low. But I don't think there is a good model, that works specifically right now that we can put your finger on one thing that will fix it. I know what won't.
It's very,
yeah, I know what won't, and that is the federal government just saying, well, I know you have this new innovative drug, but you can only charge this much, because they won't innovate and they won't develop pharmaceuticals. But on the other hand, we want to make sure patients have access to these things, and I think we're getting there. I think the Orphan Drug Program that's been in place for 40 years, and also some other things we're talking about as far as how we cut out-of-pocket costs will accomplish those goals. But we've got a ways to go, honestly.
I think that's really interesting, and a lot of my conservative friends, I remember when I worked in the Senate for a conservative Democratic senator, and I said we were talking a lot about Adam Smith and the invisible hand, but talking about areas where the market just simply didn't work is a very responsible and reasonable place for the government to take action. And a lot of my conservative friends absolutely agree with that. So it's interesting to hear you talk about that. But this Orphan Drug Act in 1983, there are a couple of times where policy seemed to spur the innovative pool. I remember the Bayh-Dole Act changed the way universities and professors and scientists could participate in the property rights. And honestly, innovation in this country went through the roof. It just spurred a lot of activity. It was very successful in terms of finding ways to incentivize more activity and investment in there. The Orphan Drug Act in 1983 also created a lot of these incentive structures. But as you said, it's 40 years ago. Do you have any thoughts, or do the Doctors Caucus, with of which you're a member, have you thought about things that we ought to be considering to say, let's take another look at that. Let's take another look at this point. Or do we have our incentives in the right place? Are we doing as much as we should do to continue to spur innovation to deal with orphan drugs and rare diseases?
Well, we've done a lot. I mean, one of the things is we've dramatically increased NIH funding and National Cancer Institute funding over the last 10 years, really, and even prior to that, so that there's grants out there available to researchers, at least in the academic space. And honestly, the private sector, the drug companies themselves are putting literally billions of dollars into innovative research and development. So I think we're doing quite a bit. I do think, though, that the main issue here is the supply chain and how we get the product from development, manufacturing to the patient, and why there's so much upward pressure on pricing in between. And I think part of that is there's not as much competition in the marketplace as there should be. And, one of the things we did in Energy and Commerce, we passed legislation that didn't make it across the House floor that would prevent large pharmaceutical companies from paying generic companies not to put a generic on the market that would compete with their drug. Believe it or not, in some cases that was happening. So I think we're doing quite a bit. We've increased the government funding availability for the academic setting and honestly also the private sector. But what we don't want to do is go backwards by then on the back end of this price fix the products at the end, because what will happen is they just won't be developed. There won't be a good business model. But I wish I had something I could put my finger on, but it's such a complicated space to work in, and it's very dynamic that, what we want to do is mostly stay out of the way and let the private sector innovate and not have policies that stop that.
Yeah, I mean, I think what I'm getting from you, and I'm feeling the vibe, is there's a bit of fragility in this research world and reaching these people who are in many cases desperate for support, then you got to deal with the cost side. And as you said, it's designed to not ever reach full market scale, right? So that, you know, you've got tensions in there to keep it going. So it's really, really interesting. And I just get this sense of fragility, like do no harm, number one. And then you look at, okay, how do we deal with the cost? How do we keep the innovation sector going? But I mean, I can say these things because I'm on the opinion side of what we do. But let me ask you another question just about COVID and where we're at.
Yes.
There's some criticism beginning to emerge here and there that perhaps the Biden administration made a mistake in pulling the plug on Operation Warp Speed too quickly, that we jumped ahead, that there were still elements of the worst pandemic that we have had in a century. And it is, you know, a real issue out there. But when it comes to science and looking at how we continue to make sure that we got vaccines in a miraculous period of time, but guess what? You know, the virus does not sit still and innovates, and that maybe we shouldn't have done that, or maybe we need to reconsider. I'd just be interested to get your take, because this hasn't really kind of hit the media full force, but I've heard some criticism even as recently as last night that we should not have pulled the plug on Operation Warp Speed.
Well, I think that's probably true. And, you know, I just want to say, you know, during the Trump administration, Operation Warp Speed resulted in really probably one of the biggest successes in the history of medicine. But in fairness, I think, you know, once the Biden administration came in, we did get the vaccines out to people and get them distributed out to people. The thing that I think we're not really focusing on as much as we should continue to is therapeutics. Because, you know, the virus is ubiquitous in our society. I mean, if you're vaccinated, you have much less chance of getting the virus. And if you do, you don't get severe illness for the most part. But what if you do get severe illness? And, you know, we need to focus, I think, some of the government type warp speed type of protocols into helping the pharmaceutical industry develop more therapeutics for the COVID virus. Because this is going to be here probably forever in the world. And what we have to do is adjust to it, have vaccines. But I would agree, don't stop this innovative process where the federal government helps the private sector in a public-private partnership develop not only future vaccines potentially, but also therapeutics as it relates to COVID. So I would agree we need to continue to do that.
Well, I just want to thank, I'll say, Dr. Larry Bucshon, Congressman Larry Bucshon from Indiana, member of the Health Subcommittee, and I really enjoy every time we have a conversation like this. I learn a lot. So thank you so much for joining us today.
Thanks for having me. I very much appreciate it.
Great discussion. Thanks again to Congressman Bucshon. And that brings us to the end of our program. A big thank you to Alexion for its support, and also to my colleagues Julia Manchester and Steve Clemens for joining me for these great conversations. And finally, thanks to all of you attendees for joining us for this discussion. For those who missed any of these conversations, we will have a video up from the event on our website shortly. I'm Bob Cusack. Have a great rest of your day and a nice weekend.